Hello everybody, thank you for doing my survey. My name is Jenny Crow, I'm a CRNA. Today we're going to be talking about practice considerations for the methamphetamine substance use disorder patients for the busy anesthesia provider. This is meant to not take up more than 5 minutes of your time. If you want detailed information, please check back on this YouTube channel and I will have another video posted that has everything more in complete detail. Our objectives for this brief overview are to learn which medications are best and which should be avoided for our methamphetamine substance use disorder patients, what medications you can give to a pregnant patient, and what to do if you have a patient who goes into serotonin toxicity or rhabdo. Methamphetamine is a substrate of amphetamine. This little methyl group is what makes it more potent. Methamphetamine releases dopamine, norepinephrine, and serotonin at levels 1,000% above basal. To give you a comparison, cocaine only raises those by 300%. You have a diffuse chain of events, as everybody knows: hypertension, tachycardia, hyperthermia, but that's related more to muscle activity, agitation, and restlessness. Please do note that serotonin toxicity symptoms are very similar to those of somebody who is using methamphetamines. The onset is the fastest with inhalation and IV, then intranasal and oral. Oral, when these patients present, you're going to see the meth mouth, of course. Duration of action of methamphetamine is very wide, 24 hours and up to 10 days, and this is dependent for each patient, how much they use and how frequently they use. So what do you do if a patient comes into the OR? First of all, if they test positive for amphetamines, I do recommend that you delay the surgery until they test negative. Things that you do not want to do not restrain the patient. This can cause cardiogenic shock and death. Avoid all beta blockers, selective or otherwise. Avoid succinylcholine, that's because of rhabdo. And you can give benzodiazepines. They say up to 20 milligrams is possible if you're giving Versed. Using rocuronium is to avoid succinylcholine. Use epinephrine, phenylephrine, these kinds of things for direct-acting vasopressors. You can use calcium channel blockers if you have a patient who's persistent tachycardic, and if they are still hypertensive, you can use nitro and nipride. If they do go into rhabdo, same like every other rhabdo patient, give IV fluids and supportive therapy, but be very careful not to push them over into the cardiogenic shock. If you have a patient who has serotonin toxicity, the very first thing you're going to want to do is give benzodiazepines, which is nice because we're giving these patients a ton of benzos anyways. You can also treat them with cyproheptadine, risperidone, or chlorpromazine. You want to control their blood pressure with nipride, and you want to avoid methylene blue, meperidine, tramadol, opioids, and beta blockers. I know that puts us kind of in a tough spot in the OR, but that is the suggestion. Danzatran Zofran says to be used with caution. There's a lot of conflicting information. Again, please see my further YouTube's video for details on that. If you have a pregnant patient, please note that neuraxial anesthesia is not an absolute contraindication, but you can have profound hypotension with an epidural or a spinal, so most people would choose not to give these to methamphetamine substance use disorder patients. They do recommend that you give benzos. I know that that's kind of contradicting to everything that we've ever learned in anesthesia school, saying that there's an increased risk of fetal malformations. That was from an old study. There's not been a lot of data that can support that. So they want you to give benzos. If you're uncomfortable as a provider giving benzos, Haldol is another really great alternative to keep these patients from getting hyperactive and restless. You can see I put the pregnancy category on these medications for you, also to give you further information. Other considerations. Large doses, like we talked about, up to 20 milligrams. You can give Tylenol if they're hyperthermic, but it's not going to reduce their fever. That's all due to muscle activity. Dex can be great to treat hypertension and also used to treat agitation, so awesome on that medication. And you might want to consider placing an arterial line to monitor their hemodynamic instability. We're talking wide swings, hypertension, hypotension, all of these things are possible in the OR. That is my brief little overview. Thank you so much. We did keep it under 5 minutes, and here's my references. Very important. yet boring. Again, check back to my YouTube's page. I have a 50 minutes lecture that will go through all of this in greater detail if you want to see it. Thank you so much. Bye.